So we're going to talk about eating disorders now. It's prevalent at 1%. Anorexia nervosis occurs predominantly in girls and women ages 12 to 30 years of age. We know that after a while, folks with eating disorders can change their appetite regulation center within the brain, which is the hypothalamus. Eating disorders are influenced by society and culture, and interestingly, eating disorders tend to be very predominant in the United States. So historically, society and culture have influenced what is considered desirable in the female body, and this has had quite an impact on the development of eating disorders, as well as these factors in the wheel: social, romantic concerns, social, cultural, genetics, vulnerable personalities. So you get the picture with the wheel. When completing assessments on, for instance, someone with anorexia nervosis, recognize that there is a big fear of obesity, and make sure that you ask them, how do you see yourself when you look in the mirror? They tend to have a heavy preoccupation with food and a refusal to eat. Again, that's unique to anorexia nervosa, and they drop an incredible amount of weight. Frequently, BMIs are less than 18%, and they're maybe 20% underweight. The weight loss with anorexia nervosa is extreme, usually more than 15% of expected weight. Other symptoms, and these are very interesting: hypothermia, bradycardia, hypotension. I think that's pretty self-explanatory. Edema, lanugo, and this is this fine baby hair, fine downy baby hair that you see in premature infants. So, and lots of metabolic changes. And here's an excellent slide showing the types of bodily effects with anorexia. So hair can become very thin, brittle, low BP, low heart rate, kidney failure, especially kidney stones, and this is frequently caused by dehydration. Skin is very dry, bruises easily. They have that fine hair growth, and that's, again, lanugo. Hormonal influences occur, and this can contribute to bone loss and problems with growing. In women, they're usually amenorrhea, or they stop their periods. They have trouble getting pregnant because they're not ovulating, which again is why they don't have periods. They're at higher risk of miscarriage, and again, that's points to their fear of gaining weight. So their malnourishment contributes to low birth weight babies, and they can also be more vulnerable to postpartum depression. And this is frequently attributed to the weight gain from pregnancy and their inability to maintain their eating practices in the postpartum period. So they get foggy in the head. Remember, your brain consumes most of your calories. About 80% of energy goes to your brain in the forms of circulating vitamins and nutrients you get from food. So they have bad memories, might be more vulnerable to fainting or syncopal episodes, can be anemic, experience bloating and constipation, weak muscles, swollen joints, and low potassium is a huge killer. In fact, people with anorexia nervosa, this disorder carries with it the highest mortality rate in psychiatry, not usually due to suicide, but due to the a huge impact on your physical functioning. And this, again, low potassium, low magnesium, and low sodium can be deadly. So look at this. 13% die within 10 years. 25% die after 20 years. You do see some full recovery, but that's only 38%. Frequently, they're in and out of the hospital, and that's 25%. It's very hard, too, to find treatment for eating disorders. It usually takes the form of inpatient treatment facilities created for the, just for eating disorders. And I never understood why eating disorder clinics actually exist for just eating disorders, because they develop a group kind of approach to behaving within those facilities. In fact, patients will converse with the other patients and tell them how they can avoid eating. And interesting, people with anorexia nervosa tend to be really wonderful cooks. They like to arrange food. They like to cook food. They like to give food away. They like to bring in all kinds of unique foods. They'll do everything with food except eat it. So moving on to bulimia. Bulimia, it's more prevalent than anorexia nervosa, and estimates are up to 4% of young women. Frequently, onset occurs in late adolescence or early adulthood, and it occurs primarily in societies that emphasize thinness. So you see a lot of the motivation is similar to anorexia nervosa. Bulimia nervosa is episodic, it's uncontrolled, compulsive, rapid ingestion of large quantities of food over a short period of time. And then with that sensation of fullness, you see compensatory behaviors of self-induced vomiting, misuse of laxatives, diuretics, or enemas. Just a very unstable pattern of eating, where fasting or excessive exercise may also occur. So you see with people with bulimia nervosa, it's episodic, and it's a behavioral thing that occurs sometimes throughout every day and sometimes sporadically, maybe once a week, but it becomes a behavior that's really difficult to control. So most individuals with bulimia are actually within normal weight range or slightly underweight, and some are slightly overweight. So normal to under to over. Depression, anxiety, and substance abuse are not uncommon. So with bulimia, the excessive vomiting, laxative, or diuretic abuse often can lead to problems as well with dehydration and electrolyte imbalances. I had a client who had such severe bulimia that she developed an inactive colon. So it's like a megacolon of her large intestine. She eventually had to go in and have a colectomy, where they removed her entire large bowel. And that was because she had this chronic inability to go to the bathroom. And sometimes she'd go as much as 3 weeks without having a bowel movement. So she had what is called an atonic bowel. So these are common findings with folks with bulimia. I like the GI tract, this chipmunk facies, or kind of a fat face, and it develops as a result of swelling of the parotid glands and perhaps the maxillary and submandibular glands. So you can see these types of enlargements. And remember, this is a very secretive type of behavior. So folks aren't going to tell you about it in their assessment. So they might have a gastric dilatation, rupture related to the force of regurgitation. They often have esophagitis because, all of that stomach acid is coming up into their esophagus. They can get an esophageal rupture or Mallory Rice tears, again, related to that regurgitation. So when they get all of this acid and vomit and stuff in their mouths, they're prone to dental enamel erosion, again, related to that gastric acidity. Cardiovascular arrhythmias, primarily related to electrolyte imbalance or, the ingestion of emetic ipecac, which ipecac, we used to give it in the ER to induce vomiting in folks who overdosed, and it will make you vomit. It will absolutely make you vomit. It always works. So they can develop an aspiration pneumonia, which is can be caused when you forcefully are vomiting. You might have some vomit that goes down into your airway. So lab values, you might see rises in amylase, abnormalities in your electrolytes, elevations in your pH and HCO3, and that reflects an excess loss of acids during regurgitation. So bad stuff, not a pretty picture. So which assessment findings would the nurse expect in clients diagnosed with bulimia? And this is important. So they're usually within the normal range of weight. So there can be neuroendocrine abnormalities, possibly hypothalamic dysfunction in anorexia nervosa. There's neurochemical influences, especially bulimia nervosa. It's possibly associated with neurotransmitters such as serotonin, norepinephrine, and anorexia nervosa might be associated with high levels of endogenous opioids. Obesity. This has been a fairly new diagnosis in terms of the eating disorders, and it's really a binge eating disorder. Obesity has been defined as a body mass index of 30 or greater. I always kind of question this because it's hard to find men who are less than 30% body mass index. And if you do find them, they look quite thin. So number of adult Americans, how scary is this? 68.5% are considered overweight, and 35% of these are in the obese range. So there's overweight, there's obese, and then there's morbid obesity. So body mass index and obesity certainly contributes to increases in morbidity and mortality. So you see this classic metabolic syndrome of elevations in blood sugar, elevations in cholesterol, and increased weight. So those three in combination comprise metabolic syndrome, which is quite common in folks with obesity. They can also develop osteoarthritis, and think about, all of that weight and how that weight puts a lot of stress on your joints. Can also develop respiratory insufficiency. So think about that when you see these folks with these big necks, so that when they're sleeping, they end up with periods of apnea. So often these folks, if you can get them to wear CPAP because they failed a sleep study, it's can be extremely helpful, especially since it can, adequate amounts of good quality sleep can contribute to ability to lose weight. So think about rest and digest. If you're not getting your parasympathetic activated at night when you're sleeping, then that also contributes to impaired digestion. So you end up with a sluggishness in your digestive system, which contributes to higher levels of stress and decreased digestion and ultimately weight gain. So a binge eating disorder, BED, is an eating disorder that can lead to obesity, and it's now defined in the DSM-5. So individual binges on large amounts of food, similar to what you see in bulimia, but it's more pervasive and it's not accompanied by vomiting. And I'll share with you, I had a patient once with bulimia nervosa who, when she would consume large amounts of food, her preference was jars of peanut butter. So she kept jars of peanut butter in her room and might consume an entire jar of peanut butter when she was binging. So biological factors, genetics, 80% of kids born to obese parents will also be obese. So you don't know, is that a genetic thing or is it related to just common dietary practices that occur within families? That's a possibility, but also twin studies support a hereditary factor. And again, those are twins raised apart. Physiological factors, lesions in appetite and safety centers of the hypothalamus can contribute to excessive eating. Sometimes people who have, and I can't think of the name of the brain illness, but they never get the sense of being full, so they're constantly hungry. Hypothyroidism, again, that can contribute to increased weight. Hyperthyroid can contribute to a decreased rate. So again, that's the influence of the thyroid on the hypothalamus. Decreased insulin production can cause weight gain. Again, that's, if you're not producing insulin and all of the cells in your body are not getting the nutrients they require for functioning, then you're just going to keep on eating. And then increase in cortisone production. So if you're using a lot of cortisol, that's your stress hormone. And again, you're slowing down or decreasing the activity of your parasympathetic nervous system. And when you do that, you're going to gain weight because you're not resting and digesting. So more factors for obesity, lifestyle factors that makes sense. Increased caloric intake and a sedentary lifestyle, and that's very common in the United States. Psychosocial influences. Some people you've heard of are emotional eaters and may have unresolved dependency needs. Fixation in the oral stage of psychosexual development, of course, that comes from Freud. So your nursing interventions for these folks or nursing diagnosis is going to be an imbalance in nutrition, less than body requirements for anorexia nervosa, or more than body requirements for someone who has obesity or binge eating, deficient fluid volume related to decrease in fluid intake, self-induced vomiting, laxative and or diuretic abuse. So altered body image, poor impulse control, lack of support, isolation, fear, and low self-esteem. These are common targets for nursing interventions in patients from all of the eating disorders. So targeting the issues, folks might be prone to having an ineffective denial related to delayed ego development and a fear of losing the only aspect of life over which they have some control. So imbalance in nutrition related to some compulsive overeating, lack of insight, poor judgment, and they might have enabling family members. I don't know if you've all seen my 600-pound life. That's an interesting show, and frequently what you'll see are very enabling family members. More issues are disturbed body image and anxiety. So a client is 5 feet 8 inches tall and weighs 105 pounds. A client has been taking laxatives daily and self-induces vomiting after eating. Which is the priority nursing diagnosis for this client? And we're looking back at Maslow, so you know that's going to be imbalance in nutrition that's less than body requirements. Now, you've got the other things are there, but the priority nursing diagnosis, or the one that you're going to target first, is the imbalance and nutrition. So that can tell a lot about what you're going to be doing in treatment. You want basic things. Be at least 80% of their expected body weight, that their vital signs, blood pressure, serum lab studies are all within normal limits, and that patients are able to verbalize the importance of good nutrition or adequate nutrition. You also want clients to recognize and verbalize increased knowledge regarding the consequences of fluid loss caused by self-induced vomiting, laxative or diuretic abuse, and the importance of adequate fluid intake, and that they verbalize events that precipitate anxiety and demonstrates techniques for its reduction. You want your clients to talk about how they can gain more control of the environment and thereby reduce feelings of powerlessness. So you get the impression where you got to work at these underlying causes of the eating disorder and not necessarily the eating of itself. However, eating and gaining weight is of primary importance for if you're working with someone with anorexia nervosa, and of course bulimia. So stabilizing their habits, and hopefully clients can, as an outcome, verbalize that the image of body as fat was misperception and demonstrates ability to take control of their life without resorting to maladaptive eating behaviors. So you want them to recognize and gain insight that just because they're seeing this in the mirror, that's really an illusion. This is the reality. Developing healthy eating patterns for weight control and weight loss, and making sure that clients with obesity can also talk about their plans for future maintenance. So you got to have a goal, because folks with obesity often gain the weight back if they don't, if they go through this period where they're, on The Biggest Loser, where they're in this frenzied amount of activity in an environment where their eating is controlled, and then they transition back out to society or back to their old habits, they tend to go back to the weight gain. So nursing care of clients with eating disorder, it's aimed at restoring nutritional balance. So again, we go back to the basics: improve self-esteem, positive self-image, and emphasis is placed on helping them to gain control of their life, especially those situations that they have felt out of control and therefore resorted to inappropriate eating behaviors. So you need to really work closely with families to help them understand the nature of the illness, the symptoms of anorexia nervosa and bulimia. Remember, these are very secretive type conditions, often hidden from family members. In fact, people with anorexia nervosa tend to present themselves wearing layers upon layers of clothing, so family members and friends don't necessarily notice just how much weight they've lost. So Management of the illness, it's all about education, teaching the principles of nutrition, helping people again control their life, express fears and feelings rather than holding them inside, and develop alternative coping strategies. And that they take medications as prescribed and don't abuse these over-the-counter medications such as diuretics and laxatives. Okay. Teach relaxation techniques, reduce impulsive acts, and develop good problem-solving skills. For the obese client, reduced calorie, nutritious diet, read food content labels, especially, once you've received that education about carbs and remembering or unlearning things about the evils of fat, because we know low-fat meals tend to be rather high in carbohydrates, so it offsets or creates problems with your insulin. Oh, and also here's very important to establish a realistic weight loss plan and a realistic plan for physical activity. So, telling someone right away, hey, you got to go out and, run 2 or 3 miles is unrealistic. So maybe it's all about starting with a walk out to the end of your driveway and back, and then increase it steadily over time. And if you set up these small, measurable goals, patients will often say, well, I went beyond the mailbox. I went out, and, walked over to the neighbors or whatever, and that was a longer distance. So there's a lot of support services available, such as Weight Watchers, Overeaters Anonymous, National Association of Anorexia Nervosa, Natural Eating Disorders. So, and there are support groups, around communities, so it's important to help your patients locate those support services. Behavioral modification, contracting for privileges based on weight gain. So the goal for someone with anorexia nervosa might be to gain 1.5 to 2 pounds per week. So you can see why they're going to be longer-term patients in an outpatient maybe a residential clinic, because it takes a long time to put on that kind of weight, especially when you can't eat or you have no appetite and your self-image is so disturbed. Behavioral modification continued. You want to make sure your client has perceived control over their eating, but a healthy eating habits, not to induce vomiting. Recognize those things that trigger vomiting. So for someone with bulimia, their trigger might just be that feeling of fullness. When you feel like you're bloated, might trigger vomiting. Staff needs to be consistent and with goals, measurable goals, and systems of rewards. You want to make sure you have your patients buy-in. So here is patient-centered care. Your patient has to go along with or abide by the contract. They need to gain the weight, and in order to earn the desired privileges. Individual therapy needs to be utilized once someone exits a residential treatment program, and that's in order to maintain what's been gained, and especially helpful when underlying psychological problems contribute to the maladaptive behaviors. Family therapy, hugely important, because often it's the family dynamics that contribute to folks feeling out of control and contributes to them feeling as if they need to control a part of their life that is realistic for them, and they see results. Psychopharmacologies. There's no medications that are specifically indicated for eating disorders. but some have been prescribed for associated symptoms. I do know that Prozac can be used with some success in folks with eating disorders. I would absolutely avoid clomipramine or anafranil because they're just lethal in overdose. Periactin or cyproheptadine can also be used. Interesting enough, cyproheptadine is a medication we're now using for treating symptoms of PTSD, especially like nightmares and flashbacks. And so that's interesting to use it for people with eating disorders, especially since there might be co-occurring personality disorders, and a history of trauma in their background. Thorazine is an antipsychotic of first generation, that's chlorpromazine, and olanzapine, another antipsychotic. But think about olanzapine they use for treating anorexia nervosa, and one of the reasons is it makes you pack on weight, increases your appetite, and people on olanzapine, heck, they can gain like 20 pounds within the first 6 weeks of treatment. Honestly, I think that this might decrease compliance with someone with anorexia nervosa when they start packing on pounds that quickly. But, remember that can be a life-saving intervention. These are medications that have been tried with some success for bulimia, and that's Prozac. Imipramine, again, that's a tricyclic antidepressant that I tend to avoid, as well as disipramine, amitriptyline, nortriptyline. Those are all tricyclic antidepressants. They might stimulate appetite, but again, I just stay away from them. Phenelzine or Nardil, that's an MAOI inhibitor, but there's so many drug-drug interactions and dietary restrictions that, it can be hard for people to adhere to it. So the number one on there for me is fluoxetine or Prozac, and it's very weight neutral. Binge eating disorder with obesity, topiramate. Interesting, topiramate is actually a anticonvulsant medicine. It has a lot of different uses. It can be helpful for preventing people from drinking alcohol. Not preventing, but treating the cravings for alcohol. So you can see there's a connection there. It can help to decrease food cravings, alcohol cravings, and it contributes to weight loss. Wellbutrin is a medicine that it can help with mood, focus, it provides an increase in energy, it treats depression, and it's one of the side effects of Wellbutrin is weight loss. Now, you're not going to see Wellbutrin, or its generic name is bupropion. You're not going to see that used with people who are prone to seizures, like someone with anorexia nervosa, and that's because they're so underweight. Anyway, they can develop seizures, and that is a side effect of Wellbutrin. Naltrexone, you can see naltrexone is also used similar to topiramate for reducing cravings. Stimulants can also be effective for helping to treat appetite issues, and that can contribute to weight loss. I think stimulants are actually a great idea. They might not be used first line because they can cause dependence and abuse. So, pharmacology for obesity treatments also include fluoxetine, especially if there's an underlying depression. CNS stimulants, Belvig, I'm not familiar with that, or Leucocerin, never heard of it. It must be a new medicine. Now, phentermine is a stimulant, and if you combine it with topiramate, You'll see this ucusemia. Anyway, I rarely ever prescribe combo medicines because you never know which one might be problematic, the phentermine or the topiramate. So why not just give them separate and see if you get a response that way, and add them one at a time. You might not need a combo medicine. They might do just fine with one medicine on its own. So that concludes eating disorders. Please read the chapters. I've also posted one of the videos from a crash course in your modules. That's about a 10-minute overview of eating disorders, and it's really quite good. Thank you.